Welcome to the first episode of Doing Good Deeds, a show where we explore the human dimensions of modern health data science and examine how the analytical tools we apply in healthcare and clinical research can impact patients, care providers, clinicians, and communities. I'm your host, Dr. Michael Pencina, Director of Duke AI Health. Today, our guest is Dr. Michael Cary. He's the Elizabeth C. Clipp Term Chair of Nursing at the Duke University School of Nursing and the inaugural Health Equity Scholar for Duke AI Health, where he is a member of our faculty council. With more than 15 years of clinical experience as a nurse, Dr. Cary is also trained as a health services researcher. His research focuses on improving the health and healthcare delivered to older adults, with a focus on minorities who use post-acute settings for rehabilitation and recovery. Dr. Cary, thank you for joining us today.
Thank you very much for the invitation, Michael.
Your work focuses on the concept of health equity, but that term may mean different things to different people. When we talk about data science being ethical and equitable, what exactly are we talking about?
So that's a great question. Let's first start with defining what equity is, and then what data science is. Because what I find oftentimes in a lot of circles in conversations that I engage with is that oftentimes equity and equality are used interchangeably, and they really have a little to do with each other. So equality is when everyone has the same starting point, and after that, it's up to you. Now, equity is acknowledging that not everyone starts at the same place, and that there are balance imbalances that exist, and we need to acknowledge those. And if we really want to commit to advancing equity, that's where we start. Now, data science is something that is more commonly known, and that is the management, the analysis, and the reporting of data to inform decisions. So when we think about equitable data science, we're really talking about, particularly in health and healthcare, we're really talking about applying an equity lens to how we manage data, how we collect data, how we manage data, how we analyze that data, and how we report that data for the purposes of informing clinical decisions.
That brings us to clinical decisions and clinical decision support and algorithms, which are an important part of data science with use of machine learning. And now, what about the intersection of health equity and algorithms, right? We had some spectacular failures demonstrated recently, and the awareness is growing that we need to have equitable algorithms. But why is it important for algorithms, and how do we do it?
So, one, as you pointed out before, the design and the implementation of algorithms have been advancing and expanding in healthcare systems at quite a large rate. But there are some concerns that exist with how data is collected, how data is analyzed, and how data is reported. So when we think about how we identify and mitigate bias in these algorithms, that's really a challenging job at this point in time, because the evidence base, whether or not the best practices for mitigating bias do not exist. So I'm excited to be a part of a committed team such as Duke AI Health, where our role is to identify and mitigate bias within these algorithms.
Right, so and we know that if we don't do it, right, the consequences can be dire. I think what comes to mind is the paper published by Ziad Obermeyer and colleagues, right, in Science, where they have demonstrated that an algorithm that was supposed to identify the need for healthcare resources I think, identified that 17% of black adults needed,
Yeah.
versus in reality, the true need was in the upper 40s, right, in terms of percentage. So huge disparity. And what we're trying to do in response at Duke is have the algorithmic governance that you're involved as our equity scholar. Can you tell us about this work, and what are you looking at as these algorithms are designed, right? The data is collected, put into it to make sure that we avoid gross mistakes like the one described by Obermeyer.
Yeah, so thank you for asking that question, because my role within Duke AI Health, specifically the ABCDS Oversight Committee, or Algorithm-Based Clinical Decision Support Oversight Committee, is twofold. One, as a leader in the Oversight Committee, I'm charged with looking at our processes and integrating equity principles throughout our evaluation processes. But also as a scientist, I'm really excited about the work I'm involved in, where I'm leading a multidisciplinary team of 10 different professionals. And the work that we're currently involved in is twofold. One, we are doing the largest landscape analysis to date, where we're combing the entire literature, looking for what are the best practices for mitigating bias in healthcare algorithms. The idea is, once we know what the best practices are, there are recommendations that can be made to health systems and clinicians for improving practice. In addition to that, we are planning to use that knowledge and then apply those mitigation strategies to several different use cases right here within Duke Health, which I'm really excited about that work.
Based on what you've seen so far, do you feel that the science is there, the theoretical background for the work has been established, or it still requires work? Because we're identifying a lot of publications, obviously, through the search, and a lot of reputable people are expressing their opinions or building on other research. Do you think we're there theoretically and we just need to apply it, or it's work in progress and development where the science is still developing?
I think it's the latter. I think that it's work in progress. The science is still developing. And that's exciting, again, because we are forging that path for other project teams, other clinicians, other healthcare systems. But it still is lacking. I think there are a lot of barriers still to advancing that work, such as the lack of disparity that exists within project teams. There's oftentimes very smart people developing algorithms, not necessarily with a healthcare background or experience. There's also a lack of racial and ethnic diversity within these different project teams. And I would also add that there is a lack of healthcare disciplines and diversity there. Oftentimes, there could be physician representation on these project teams, but there are rarely ever nursing representation on those project teams, which I find concerning, given that we are part of the largest healthcare workforce.
Right. No, I think that's an excellent point, right? And you come from the nursing background, and nurses are such an integral part of our healthcare systems and healthcare delivery. And so, where are nurses in the process of algorithms development and all this promise, but potential harm? What's the engagement of nurses and nurses' take on what's being thrown at them?
I think that nurses are heavily interested in contributing to the design and also the implementation of these algorithms. I think oftentimes, though, you don't see a lot of them at the table. I think that speaks to not just a nursing problem, but more so a lack of clinical training at large. Clinicians across the board are not trained as computer scientists, and they shouldn't be. but they also are not trained in identifying or developing protocols that can identify and mitigate algorithms at all. And I think that that is a very large gap in our training. And I think if that we're going to advance health equity in particular, we really need to start thinking about how do we create evidence-based curriculum for training our clinicians.
Right, right. So that's very interesting, right? So we need to develop the methodology, the science, and the education that goes hand in hand with it. No, I think that's a very important point. It also reflects, I'm as a statistician by training, I'm thinking about the statistical aspect of it, where the metrics are not there either, right? The recent paper we published in JAMA identifying disparities in stroke algorithms, and we struggled with the performance metrics because we can do comparisons, right? Do the analysis within black adults, within white adults, about how do you quantify that the algorithm has bias that can lead to differing healthcare decisions. And I'm seeing more research emerging in this space, but it's just emerging right now. So I think we are in a field that continues the development. And turning more to you on a personal level, why is it important to you? And I think, what are you most excited but also most worried as we progress towards more use of algorithms and then the concern of health equity?
Yeah, thank you for asking that question. So this is where my passion exists. I've been a nurse for nearly 20 years, and over that span, I have worked to improve health systems and social systems that are ill-equipped to really deliver care to older adults, particularly with social and economic challenges. I think also, as a scientist, I'm dually trained, both as a health services researcher and as an applied data health scientist, which few exist in the entire country with that type of background. I would say, lastly, I'm also personally drawn to this as a black man growing up in rural central Virginia, where I've experienced my share of racism and discrimination. And I've also lived in rural, remote areas where it was little to no health resources in that area, and I had to drive, and my family had to drive nearly an hour to get and access care. So I think all those things together has really drawn me to this work, and I think has positioned me well to make a meaningful contribution.
Right. No, I think it's really important that I want to reflect back, right, the stroke paper we just published. What we found is that a simple algorithm which uses patient-reported outcomes as opposed to more accurate clinical measurements or sophisticated AI algorithms performed as well as the more technically advanced tools, which to me speaks volumes of the importance of the patient voice and community engagement in the real purpose of algorithms, which should be prevention, right? Because we're not doing the algorithms to be fancy or to risk stratify, to I don't know, to just save resources. I think the entire goal of using algorithms is to identify patients at the highest risk of disease and prevent the disease. And I think the potential, as I'm understanding and hearing what you're saying, really lies in engaging the patient and the community.
Absolutely.
What can we do to make things better?
First, I think we can start by engaging patients in the community. I think if you look at the literature, there are few papers that exist that involve patient voice and community engagement in the design of these algorithms. I think that is one way that we can potentially address bias in the design of some of these algorithms. So I think maybe having a patient advocacy group that's established here in the health system, or adding certain patient advocacy groups or community engagement groups as a part of our research teams is where I would start.
Do you think patients will respond? Like when you, I don't know, reflecting on your personal background or patients in rural Central Virginia or North Carolina, will they have interest? Will they? How do we demonstrate the value of this effort to them?
I think this is an incredibly important question. I think that healthcare is challenging in and of itself. And I think that oftentimes patients who are admitted to healthcare systems are incredibly vulnerable because they are there for an acute reason of some kind. So I would say that it could be potentially overwhelming to kind of have a look underneath the hood of some of these algorithms and share that with patients. But I think we have a responsibility to educate them and to let them know that these different algorithms are helping us make and inform clinical decisions about them. And they need to be a part of that.
Right. And I think that's one critical component. I think there are so many areas that we touched on, right? It's hard to do it well from the design stage to successful implementation. Anything in this process, in addition to what we discussed, that you'd want to highlight?
So I would say that some of the work that we're coming across right now in the development of the many frameworks that are being created now to kind of evaluate algorithms, particularly in healthcare, lack health equity by design focus. And what I mean by that is health equity needs to be a core design function of the algorithm. It needs to be something that is considered in the beginning, in the design, in the evaluation, and also in the implementation and the monitoring of the algorithm. I think if we can kind of thread that core concept through our process, it would help to kind of identify and mitigate bias that are created in our algorithms.
I think that's a really, really important point, right? It's the design from the beginning with the end goal in mind, right? So our name of the show, it's DEEDS, Duke Ethical and Equitable Data Science. And we want to be doing good deeds. We want to kind of juxtapose it against the general perception of AI being maybe this little bit evil force coming in where machines and computers will be telling us what our healthcare choices or decisions should be, and then almost steering us, right? We want to do the opposite, bring the human component to it, right? And change the perspective from the more evil and distrustful or not trustworthy into the doing good deeds, into the positive. And I think what you outline, the concepts of equity by design, ethical data science by design, are tremendously important to accomplish it and make it happen. And what about transparency in all of that? Where does it fit, and how are we to be transparent without being transparent in the legalese style, where we're going to throw, 20 pages of statistical gibberish at patients, right? That's not transparency.
No.
On the other hand, the black box solution, we can't tell you what it does because it's so complex, also doesn't cut it.
Yeah. I think when I think about transparency, I think about it from the patient perspective, and I think about it from the clinician perspective. From the patient perspective, we've touched on that already about how we need to be involving them into not only the design of these algorithms, but also into care decision making. In addition to that, I think from a clinician perspective, we need to become more comfortable with registering algorithms, providing bias assessment in their results, and the strategies that we use to mitigate bias. without the fear and concern of some kind of legal reprimand. I think that if we can establish that as a community, as a profession, and also at the federal level, I think that that would go far in terms of increasing transparency.
Right, and engaging the patient and community voice, right?
Yes.
Because the transparency or equity shouldn't be done to them or at them. It should be done with them together, like we discussed. So hopefully the conclusion is maybe we can be, we should start thinking about doing good deeds by design.
Absolutely.
And that's our show for today. Thanks again to Dr. Michael Cary for an excellent and thought-provoking discussion.
Thank you, Michael, for inviting me to Deeds. I appreciate it.